Hi, and welcome back to the WHYO-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. Disclaimer. All content and details, as well as education shared on the podcast, are the opinions of the speaker and for informational purposes only. Please consult with a certified medical professional regarding any questions or concerns, as this podcast should not serve as a diagnosis or replace the information that you have received from a healthcare provider. Hi, I wanted to take today's podcast to talk a little bit about habit breakers and the pros and cons of habit breakers and how they potentially interfere or support therapy regimen. During my 20 plus years in the field, I have definitely come across many different types or many different patients or practitioner dental providers utilizing habit breakers. And especially with patients that are seen by myofunctional therapists, even speech pathologists as well, that are treating oral motor or feeding. For many of these patients, their oral cavity appears smaller. And is it necessarily smaller? I think the issue is that because of what their symptom is or their issue may be, such as a tongue thrust that is creating a high or narrow or both high and narrow palate, or their airway is compromised with enlarged tonsils, or they're unable to breathe through their nose, so they have to breathe with their mouth open, or they have a tongue tie and their tongue is fixed to the base of the floor of the mouth. And for many of the patients that I've come across as a speech pathologist and myofunctional therapist, oftentimes the child, when they're getting a rake or a crib, one, it's affixed in their mouth, so it cannot be removed. Two, it's usually covering their alveolar ridge and their incisive papilla. And when the patient lays down at night, because especially if they're tongue-tied or had a tongue tie, it was released, but therapy was never done, or they have enlarged tonsils. When they lay down, their tongue is not able to be elevated to the hard palate, so it's kind of falling back into the airway. That, in combination with this encroaching piece of metal, is often suffocating for these patients. They feel anxiety, they feel anxious, they feel like they can't breathe. And I cannot tell you how many times that the mom or the dad brings a child in and the child has literally ripped the appliance out of their mouth themselves. So as speech pathologists, myofunctional therapists, our goal is, for many of our tasks, whether it be myo tasks or myo goals, feeding goals, oral motor goals, articulation goals, it is extremely important for us to have access to the alveolar ridge and the incisive papilla. So if a patient comes into our office and they have a rake or a crib, we will often tell the patient that we are not going to be able to do therapy, depending on the type of therapy, but many of the therapy approaches, until that appliance is removed. And our concern is, one, we don't have access to the alveolar ridge and the incised papilla, which is so important with so many goals that fall under that myo speech umbrella. But we also find that our patients just change their habit. So if they are utilizing a habit breaker because they're resting their tongue on their upper dentition, one of two things happen. Either the patient or the child will say, okay, well, I can't thrust on the top teeth, so I'm just going to change where I thrust and I'm going to thrust on the bottom teeth. That's not helping anything. And we're not retraining the tongue. We're just limiting its ability to, we're interfering with the tongue's ability to push on the teeth, but we haven't changed anything. So when that appliance comes out, we didn't teach the tongue or strengthen the tongue to do and to sit where is necessary, or to access the alveolar ridge or the incised papilla for their goals. Instead, they do one of two things. They change it and they start resting on the bottom, or they are not deterred at all. They become desensitized to the rake or the crib, and they'll just rest their tongue on it now. Or we'll have the patients that actually will sneak their tongue around the rake or the crib so that it can continue to engage in this adverse habit, or this adverse behavior. So it's, for our purposes, rakes and cribs, especially with speech and myofunctional therapy, are not recommended. At least that's how we envision it, because of all of those previous things I just mentioned. What we would normally recommend, if we have to recommend anything, is something called tongue tamers. They are affixed to the dentition, and they have a little bit of a prick or a prong on them. So if the tongue does get too far and get against the teeth, it is reminded that it needs to be moved back. And what our hope is that because we're still able to access the alveolar ridge and the incised papilla, we can work on building the tongue strength, working on re-educating that neuromuscular system, retraining the motor plan, and that all those tongue tamers are doing are acting as a reminder. So if I slip too far forward, my tongue is on my spot, but I have a lot of saliva, so I slip forward. It's giving it a reminder, like, okay, I know I need to go back a little bit. So they know where their tongue needs to be. It's just reminding them where it has to go. Unfortunately, especially in a world where clear aligners are being utilized regularly, whether it be for retention or as part of intervention, we are unable to use tongue tamers with a clear aligner. And I understand, as a patient, as a teenager, as a child, you may not want to have those big braces on your teeth. It is often difficult with those tongue tamers to even utilize a traditional retainer. And our concerns often with traditional retainers is that the acrylic or the plastic that is being utilized is covering the hard palate. So now the tongue is not able to make contact to when it's trying to swallow, or when it's speaking, or to maximize airway space. So it comes to a point where we're trying to figure out, okay, we really think this patient needs the additional reminder. However, what is the effective tool to utilize? And I know I mentioned a few episodes ago, I recently patented an appliance called the Spot Pal. And the Spot Pal came about, and I mentioned this in the past, one during COVID, when everything got switched to virtual therapy, and I was concerned about our patients not getting the full benefit of the therapy because we couldn't ultimately see if everything was being done effectively and correctly. That was one part. The second part was, it's so hard in this day and age for patients to not only commit to a therapy regimen, but then to commit to home practice. And sometimes we are able to be very effective and successful when it comes to giving them conscious exercises. Do this, do this, do this. But when it comes to taking that conscious piece and transitioning it to a subconscious piece or a subconscious approach, that is often difficult because we're relying on the parent or the patient to report back to us. And again, they have to be able to recognize when they're doing things incorrectly first in order to help support them do it correctly. And if we're not able to look in our patients' mouths 24 hours a day, 7 days a week, then we're never able to determine that. And we don't get to provide the patient with, or we can't really support a passive therapy regimen in addition to an active therapy regimen, even though we try and we utilize tons of tools that are effective. But again, we are counting on the patient or the parent to say, yes, I checked and their tongue was on the spot or in the correct place, or the therapist, when I had the child in therapy, I checked and their tongue was resting correctly. Because when we're asking to look, or we're asking the patient, or the parent is asking the patient, or visual asking to see where their tongue is sitting, we're still giving them a conscious reminder, and we have no idea if in that moment they put their tongue where it needs to be. They fix their placement, if that cues them to do things correctly. So now we're trying to support passive therapy. We want to be more effective with subconscious therapy. We want to make sure that our patient is hitting the right spot, or resting their tongue in the right spot, or utilizing the proper tongue position. And above all else, we want to provide the additional insurance, especially if the patient is going through orthodonture, that once they're completed with therapy and completed with their orthodontic treatment, that the patient is going to be able to retain what they've learned both in therapy, and they're going to be able to retain this beautiful occlusion that has now been corrected. So when I patented the appliance, the Spot Pal, those were my objectives, was to make sure if there is it's a virtual treatment, that we know exactly where the patient's tongue needs to be, and we're giving them a tool for them to utilize so that we can say, put your tongue on the spot dot, and they know where that goes. We also want to be able to provide the patient with a cue so that if their tongue does slip forward of that spot dot, there are pokes on the back of the teeth that remind the tongue, oh, you went too forward, you need to go back. But then one step further is that when they're in a retention appliance, and a Spot Pal is a clear aligner, it can be utilized as a retention appliance, and especially with tongue thrusters, whether they're thrusting on their upper dentition or their lower dentition. If it's their upper dentition, I highly recommend utilizing a Spot Pal on top and a clear aligner on the bottom. The Spot Pal will retain the bite, but what it does include is a place where their tongue needs to rest so they have a reminder. It includes pokes on the back of the teeth wherever the tongue may be or had been pushing forward in the future, in the past, whether it be on their upper dentition, their upper central dentition, if it's on the lateral dentition, if it's on both. We can provide tactile cues to remind the tongue where it needs to go. And in addition to that, we can have our patients wearing a spot pal on the top, a clear aligner on the bottom, and or just a spot pal on the top if it's not a patient that's actively in ortho, and they are able to occlude naturally, so there's no space between the upper and lower dentition. They're able to engage all of the muscles that are necessary for speaking and swallowing in an effective way, specifically the masseters, the jaw, the tongue. And we are also able to provide this appliance, which is thin. It doesn't interfere with their speech. So they can wear it in school, they can sleep in it, they can wear it when they're watching TV, they can wear it when they're driving in the car. And what it's doing is having that support for passive intervention. And it also then can be utilized as part of a therapy regimen, or for those individuals that don't have access to a myofunctional therapist or speech pathologist, or cannot afford to engage in such therapy, it's still able to target the goal of keeping the tongue off the teeth, supporting proper resting posture, and supporting and maximizing airway space and focusing and allowing our patients to breathe through our nose. So I definitely suggest looking into the spot pal, because as far as a habit breaker goes, it is able to target noxious habits like thumb and finger sucking, nail biting, tongue sucking, which no other appliance is able to do. It is completely customized. It provides a place for their tongue to rest. It has pokes that can be added any place to remind the tongue where it needs to sit. And it also can accelerate the progress in therapy, because what normally could take 3 or 4 sessions to say, all right, put your tongue to the spot, and the patient is groping and can't find it, and they're not able to execute it correctly on demand, they're able to do it immediately. So instead of it taking 3 sessions to effectively get the patient to get their tongue to the spot on command, they can do it in their first session. They have a lot more passive intervention from earlier on, which is then supporting that subconscious piece. And that is accelerating their progress and their course of treatment, which is always a benefit for us as clinicians, because we want them. And as I always say, we're only as successful as the patients we successfully discontinue, or that we successfully discharge when they've met their goals. And if we can effectively do that without losing their interest and causing frustration, then it is a win-win. And I think the spot pal can definitely be a benefit to treatment. For more information, check out thespotpal.com.
I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.